The next session is the symposium courtesy by Takeda, titled New Development on Management of Acid-Related Upper GI Diseases in ASEAN, moderated by Professor Somchai Leelakusolvong. Professor Somchai is a professor of medicine at Gastrointestinal Division, Siriraj Hospital, Faculty of Medicine, Mahidol University, Thailand. Currently, Professor Somchai is a council member of the Asian Pacific Association of Gastroenterology, Director of the Motility Center and Siriraj Endoscopy Center at Siriraj Medical School, Vice Director of Siriraj Piyamahakarun Hospital, President-elected of Gastroenterological Association of Thailand. And next year, the Asian Pacific Digestive Disease Week 2023 meeting, which will be held in Bangkok, Thailand. Professor Somchai will be a Congress President of this meeting. And also joining us live from the Philippines, Professor Jose Sollano, Professor of Medicine at the University of Santo Tomas, Faculty of Medicine and Surgery, Manila, the Philippines. Professor Sollano is the past President of the Asia Pacific Association for the Study of the Liver. Professor Sollano is also past President of the Hepatology Society of the Philippines, Philippine Society of Gastroenterology and Digestive Endoscopy, as well as the Philippine College of Physicians. Please give our moderators a warm welcome.
Thank you very much, Mr. MC, for your kind introduction. Good afternoon, everyone, and welcome all of you to join the Takeda Symposium entitled New Development on Management of the Acid-Related Disease of the Upper GI Disease in the Asian. My name is Somchai Leelakusolvong, as you already known about that. First of all, I would like to sincerely thank the Takeda Pharmaceutical Company and also the organizing committee to invite me to be a moderator in this session. In addition, not only me, but also we have Professor Jose Sollano from Philippines. We will join our symposium in Zoom. He is already here. Yeah. So let's start with the first speaker. Today we have two speakers. The first speaker is Dr. Supphamat Chirnaksorn. Dr. Supphamat Chirnaksorn. She is graduated from Ramatipati Hospital, Mahidol University, and went to UK as a visiting researcher in the section of the molecular gastroenterology at St. James University Hospital, University of Leeds, UK in 2018 and 2019. Now serve as a clinical instructor in the Ramatipati Hospital, Mahidol University, and interested in the field of the GI motility. She is going to deliver a talk entitled Role of PCABs in the treatment of erosive esophagitis. Professor Supphamat, please.
Thank you. Good afternoon, everyone, and welcome to my presentation. My name is Supphamat Chirnaksorn from Ramatipati Hospital, Mahidol University. First of all, I would like to thank the organizer of this meeting for inviting me here today, and also would like to thank Professor Somchai, one of my great teachers, for kind introduction. As you can see in the screen, that my topic today is to talk about role of potassium competitive acid blocker in the treatment of erosive esophagitis. Here is my disclosure in relation to this presentation. In my talk, I will give you a brief summation of gastroesophageal reflux disease and talk about role of potassium competitive acid blocker or PCAB in erosive reflux disease. It will take about 20 to 25 minutes to cover this issue. So let's start with the gastroesophageal reflux disease definition. GERD is a chronic, relapsing, disabling, and complex GI condition. And as referred to Montreal definition, GERD is a condition which develops when the reflux of gastroduodenal content into esophagus causes troublesome symptoms and/or complications. Patients can come to you with high heterogeneity in symptoms, ranging from silent acid reflux or classic heartburn and regurgitation, or come to you with complications as dysphagia, or come with extra esophageal reflux, such as chronic cough, hoarseness, or erosion in the dental, or it can come with chest pain simulating coronary artery disease or non-cardiac chest pain. GERD is a common in Western countries, affect around 13% of the population worldwide. Although it started to be less common in Asian countries, the prevalence of GERD is now more than 10% in Japan, China, and India. Not only huge burden on health-related quality of life and also decreased work productivity, GERD plays an important role in an occurrence of esophageal adenocarcinoma. The two main phenotypes of GERD by using endoscopy was classified into non-erosive reflux disease or NERD and erosive reflux disease or EE. A data from epidemiological study show that the prevalence of erosive esophagitis is around 10 to 25% in Western countries, while only 5 to 17% in Asia Pacific countries. Among erosive esophagitis patients, we can find advanced erosive esophagitis grading, i.e. erosive esophagitis LA class D and C in 15 to 30%, and may come up to 37% in the elderly. Despite the minority of patients have erosive esophagitis, but the erosive esophagitis is resulting in more severe symptoms and all complications. The main aim of EE treatment nowadays, including to relieve GERD-related symptoms, to heal and maintain EE remission, to prevent complications, and most importantly, to improve quality of life. Acid suppression considered as a mainstay of treatment in erosive esophagitis treatment, and you may know that what PPI represents a drug of choice in the last several decades. Despite the proven efficacy in relief symptoms of GERD symptoms and as well as mucosal healing, there are few PPI limitations. Firstly, many early generation PPI show delay in action of onset, so several dosage cycles may be needed until maximal efficacy are fully reached. Besides, PPI may be inadequate to fully overcome nocturnal acid breakthrough. This is an example of PPI limitation. As you can see here, you can see PPI failure rate in erosive esophagitis healing from the study of Castell, who were randomly the patient with erosive esophagitis, more than 1,000 patients, received PPI either lansoprazole or omeprazole, and follow them for 8 weeks. As you can see in the picture that well, EE healing rate at 8 weeks is found in 6.7%, 8.4%, 11%, and 40% in erosive esophagitis LA class A, B, C, and D respectively. Interestingly, in recent large real-world survey in Japanese EE patients, we can find mean healing rate in EE was only 60%. And another problem of PPI treatment in erosive esophagitis is they have high relapse rate. As you can see in this slide that after PPI discontinuation, we can see relapse rates in EE around 90% and 75% in non-erosive reflux disease. Even while on PPI, you still see the recurrence rate of the gastroesophageal reflux disease in 10%, 29%, 60%, and 41% in LA class A, B, C, and D respectively. So PPI limitation may be a reason behind the unmet needs of GERD treatment. Stronger acid inhibitory drugs may be needed to resolve all the problem. So today we will introduce you to know about vonoprazan. Vonoprazan is a novel orally active potassium competitive acid blocker delivered and synthesized by Takeda Pharmaceutical Company. Received its first global approval in 2014 and launched in 2015 for use as acid suppressant. This drug displays a rapid, potent, and sustained acid inhibitory effect and have potential as a new therapeutic option in GERD. A detail in pharmacology in this drug may be show you in next lecture. From now on, I will show you a data or a study of vonoprazan in erosive esophagitis. First study that we can show you is a phase 2 multicenter randomized double-blind parallel group dose-ranging study, non-inferiority study, to see the efficacy and safety of vonoprazan for initial treatment of the erosive esophagitis. We randomized 732 EE patients randomly to receive either lansoprazole 30 mg once daily compared to vonoprazan in all range of dose from 5 mg, 10 mg, 20 mg, and 40 mg. And the primary efficacy is erosive esophagitis healing rate at week 4. As you can see in this slide that the vonoprazan at all range of dose can show the non-inferiority to the lansoprazole 30 milligrams. And about the treatment adverse events, as you can see the data from the table that there are comparable adverse events between vonoprazan and also lansoprazole. Even in the higher dose of vonoprazan at 40 milligrams, the adverse event is comparable to PPI. The most common side effect of the vonoprazan is nasopharyngitis, followed by diarrhea. Subsequently, after phase 2 randomized control trial, we can see the data from phase 3 non-inferiority trial conducted by Ashida and team. Study in Japanese patients who have endoscopically confirmed EE, who randomized to short-term double-blind 8 weeks and then long-term single-blind maintenance therapy for 42 weeks. Compare short-term treatment with vonoprazan 20 mg to lansoprazole 30 mg. And the patient who have endoscopically confirmed healing rate at week 2, 4, and 8, who were random to single-blind study maintenance phase for 52 weeks. As you can see, the healing rate of the vonoprazan and lansoprazole, you can see the healing rate of the vonoprazan is 99% compared to 95.5% in lansoprazole group. The conclusion from this study is vonoprazan is non-inferior to lansoprazole in EE treatment and was well tolerated. And when you divided the data into 2 groups, the first one is the low-grade erosive esophagitis and high-grade esophagitis. You can see that vonoprazan is more potent in healing of severe grade of erosive esophagitis. And another data that didn't show in this picture is in patients with CYP2C19 extensive metabolizer, the EE healing rate can achieve in vonoprazan group more than in PPI group. And then another phase 3 double-blind, double-dummy parallel group was conducted outside Japan because the previous study is occurring only in Japanese patients. This study is expand outside Japan in Asian countries. It's including in mainland China, South Korea, Taiwan, and Malaysia. Enroll 481 erosive esophagitis patients to establish non-inferior efficacy of vonoprazan and lansoprazole in non-Japanese patients. And as you can see, the data can show that vonoprazan can be used in Asian population outside Japan, and the treatment adverse event is comparable to the PPI group. And as PCAB or vonoprazan claim that they have a rapid action of onset, so they should provide heartburn relief sooner than PPI. So this randomized control trial conduct to see this result. And as you can see in the graph that vonoprazan 20 milligram can achieve complete symptom relief in the first week at 31% compared to 12% in the lansoprazole group. So provide heartburn relief sooner than lansoprazole. And another problem that I mentioned earlier, that is maintenance therapy in erosive esophagitis is one problem. So a aforementioned study by Ashida team that I talked to you earlier, that they have 2 phases in the study. This is data from the phase 2 long-term maintenance therapy, 42 weeks. Compare vonoprazan 10 milligram and 20 milligram to see the EE healing rate at week 24 and week 52. As you can see, at week 52, less than 10% of the patients have EE recurrent, and also in the week 24 too. And another maintenance treatment of erosive esophagitis. This data compare vonoprazan and lansoprazole. The previous study compared between the 2 doses of vonoprazan, but this study compared to the lansoprazole 15 milligram. As you can see, the EE recurrent rate at week 24 in lansoprazole group is 15% compared to 5% in vonoprazan 10 milligram group and 2% in vonoprazan 20 milligram groups. So you can see the low recurrent rate in vonoprazan group when compared to lansoprazole group. And this is a maintenance therapy data from outside Japan, because the 2 studies have a similar study. We can see the short-term healing rate and long-term. And you can see that the EE recurrent rate of the lansoprazole is higher than in the vonoprazan group. As you may know that the data of vonoprazan in the Western population is sparse. But last year, the Falcon pharmaceutical company has announced about the outcome of the phase 3 trial non-inferiority and pre-planned exploratory superiority test in vonoprazan and lansoprazole group to see the erosive esophagitis healing in the Western population. This conduct in Europe and also United States. We include the erosive esophagitis patient around 1,024, and among this we can have the LA classification D and C in around 34%. Compare the healing rate at week 4 and to see the maintenance phase at week 24. This is the data that announced on October last year. As you can see, the healing rate at week 4 and week 2, the vonoprazan group have a high healing rate of EE healing rate than lansoprazole, both week 4 and week 8. And in maintenance phase, as you can see, the lansoprazole has a lower healing rate when compared to the vonoprazan, both doses. And overall, the safety result of vonoprazan that observed in the Falcon EE were consistent with the result that observed in the previous clinical study. And this data leads to FDA consider to approve for this drug in the Western country, but now not approved yet. So in summary, GERD is a common and novel potassium competitive acid blocker displays several benefits over PPI, such as rapid onset of action, more potent acid inhibition, and more sustained acid suppression. The non-inferiority of vonoprazan over PPI has been proven in clinical trial. to date, both Asian and non-Asian populations. So vonoprazan might have the potential option of erosive esophagitis management, especially for the higher grade of erosive esophagitis. Thank you for kind attention.
Thank you very much, Dr. Supphamat. So we will leave the Q&A in the end of this session. So the next speaker would be a very renowned speaker that will be introduced my co-chair, Professor Jose Sollano. Jose.
Yes, thank you very much, Somchai, and thank you very much for this invitation. I hope that I would have traveled to Bangkok to join you, but you know, it's a little busy now and life is back to normal. So congratulations for a successful meeting so far. So the next speaker is very, very well renowned and a multi-awarded expert gastroenterologist who has been able to lead the Asia-Pacific group of gastroenterology for some time. He has held many important positions in Asia-Pacific as well as in the world, and including, of course, the president of the Asian Pacific Association of Gastroenterology. Currently, he is Professor Emeritus from GH Medical School. Ladies and gentlemen, I am very glad to welcome and bring to the podium a good friend of mine to speak on pharmacology and clinical experiences with PCABs, Professor Kentaro Sugano. Please, Ken.
Thank you, Professor Sollano. I miss you personally at this occasion, but I'm glad to see you very, very healthy and looks the same. And I'm also grateful for the kind invitation, Varocha Mahacha and Leelakusolvong for this occasion. Thailand is also always a wonderful country to visit, and very charming and very, very kind and well accepted hospitality. So I'm always a pleasure. I enjoy pleasure to visit here. But because of time, I will just go on to the pharmacology and clinical experience with PCABs. And let's first take a look at the basic mechanisms of PPIs. PPIs are very, very good drugs and one of the world's most marketed and sold drugs still after 20 years of 30 years of introduction. As you remember very well, this is the acid pump here. Oh, some movement is a little bit awkward. But anyway, to act to the acid pump, HKATPase, PPI requires two steps. One is the acid catalyzation to prodrug to the active compound, which is unstable. And then this sulfhydryl compounds bound to the cysteine residues of HKATPase, which might be different from PPI to PPI. And this cartoon shows the pantoprazole case, which bind to the cysteine 813 and 822. Then this binding actually restricts the conformational changes of PPI. So that's why PPI act to restrict this movement of the ions. How about the PCABs? This is nicely illustrated by the recent paper written by Dr. Abe in Nature. And they crystallize the HKATPase together with vonoprazan. And it nicely shows the vonoprazan intercalated potassium channel, potassium binding site. And they block the binding of potassium. Thereby, no more conformational changes occurs. And as you know, there are several steps required for expelling the hydrogen ions. And this E2P phase, which faces outward, to incorporate potassium, but this place was blocked by PCABs. That's why this series of events won't happen. That's the major reason of PCABs action, mechanisms of action actually. And two important things is that PCABs doesn't require any activation process. The second, this binding is a reversible process. So these two actually points discriminate PPI against PCABs. And there are several PCABs so far developed. The old prototype is this Shearing's 28080, which was developed almost at the same time at the PPIs, 1980s. This prototype was developed, but unfortunately, because of the liver toxicity and other things, the development was stopped. And then Astra developed another one, linaprazan, which went to the phase 3 clinical trials. But again, it shows a nice profile, but because of the liver toxicity, they didn't develop further clinical trials. And currently, 3 different kinds of PCABs are on the market. 2 of them are developed in Korea, and revaprazan was the first PCABs which was introduced in the market, but didn't sell well. Probably Professor Kim know much better. And the second is vonoprazan, which was described by the previous speakers. And we have 8 years of clinical experience on this. And tegoprazan, which was originally developed, Rock Warrior, a venture business, originated in Japan, and then license was sold to a Korean company, and the Korean company actually developed into the clinical use. And now Korea is using tegoprazan, but not us. But probably in China, they will introduce tegoprazan and also. And vonoprazan is widely marketed in the Southeast Asia as well as in the US. And as a previous speaker showed that this is the pharmacokinetics of vonoprazan, the vonoprazan won't be affected by meal intake. So you can take either before breakfast or after meal. Any time, it's okay. This is a little bit different from the PPIs. And also, as the previous speaker pointed out, it started immediately, very rapid onset, and have more profound acid controls, as you can see here. And also, the duration of acid suppression is much more longer than the regular PPIs. If you use, for example, 40 milligrams of vonoprazan, almost you can hold the intragastric pH above 4, 24 hours. So this is the advantageous point that the cover, the short point of the, oops. So the vonoprazan was introduced in Japan 2015 into the marketing. And we have several indications for this. And I'll show briefly of the refluxive esophagitis. Previous speaker already told me, so I skipped this one. And then maintenance was superior than lansoprazole, especially in the high grade of erosive esophagitis. And network meta-analysis data shows the vonoprazan is a favored drug against PPIs in most cases. And especially this is good for PPI-resistant erosive esophagitis. Even if PPI failed to treat heal the erosive esophagitis, if you use vonoprazan, either 20 or 40 milligrams, the high rate of healing was achieved. And however, one weak point is that this vonoprazan failed to show any advantage against NERD, non-erosive reflux esophagitis. However, tegoprazan showed a superiority on the NERD. This is one merit point. I skipped this slide because I thought the previous speaker might touch upon this one. So the Japanese GERD guideline published this year shows that for mild reflux esophagitis, you can use PPI as well as vonoprazan. Sorry for the busy slide, but for the difficult GERD, severe reflux esophagitis, vonoprazan was the preferred drug for this group of patients. However, for NERD, PPI is a favored drug, and probably in Korea, tegoprazan as well. How about peptic ulcer disease? Peptic ulcer disease, you can choose either PPI or PCABs because there is no difference at all. However, if you look at the delayed bleeding after ESD, vonoprazan is superior to the PPI, especially if you use the bigger ESD therapy, you can better use vonoprazan to prevent late bleeding. And how about NSAID ulcer recurrence with vonoprazan? We did these studies with Mizokami and al. And this shows non-inferiority, but if you look at the data, recurrence rate was a little better. And also the same for the LDA, low-dose aspirin ulcer recurrence with vonoprazan. And the gastric duodenal bleeding is much lower if you use vonoprazan for maintenance. And in the real-world data, we analyzed millions of, database, and showing that the patient with multiple antithrombotic agents, upper GI bleeding was lower, but there was no, statistical significance because of the number of patients using vonoprazan was relatively small at this stage. But nevertheless, if you are using antiplatelet therapy, vonoprazan might prevent bleeding, especially high-risk people. Professor Chan might consider this option in the future. But how about H. pylori eradication with vonoprazan triple therapy? As you are quite aware, vonoprazan is better than, especially in the CAM-resistant strains, to achieve the high rate of eradication. And if you failed with this triple therapy, remember this one is only 7 days and lower doses of clarithromycin, 1.5 gram, and of amoxicillin and 0.8 gram of clarithromycin. So relatively short and lower doses of triple therapy are allowed for us. And even if you fail, if you switch it, vonoprazan, amoxicillin, metronidazole, almost 100% of eradication can be achieved. And now recently, a vonoprazan-based triple therapy was shown to be superior to other combination by the network meta-analysis published recently by Theodora Rokas. And also, we are looking at the vonoprazan dual therapy to further cut the clarithromycin use. And indeed, this prospective randomized trial showed a similar efficacy of vonoprazan dual therapy. So our next probably step should use vonoprazan dual instead of vonoprazan triple. However, in a recent clinical trial done in the US and Europe, showed a relatively poor result compared to the Japanese study. As you can see here, vonoprazan dual shows similar efficacy with vonoprazan triple and superior probably to the lansoprazole triple therapy, although overall success rate was much lower than the Japanese data. Why is this? It automatically switched to the next one. So the key point is that the compliance rate of these trials was 10% lower than the Japanese trial. That explains why ITT data were a little bit lower than the Japanese trial. But nevertheless, it clearly shows that the vonoprazan triple therapy is superior to lansoprazole-based triple therapy. But if you probably use and educate patients, the eradication rate will be greater. And how about tegoprazan triple therapy, which was just published, but it was not so good. As you can see here, only 60% of ITT success rate on ITT data, and similar to the lansoprazole data. Because of the potency of the acid suppression might not be as good as vonoprazan. That might be the reason. Other tegoprazan data for GERD also shows a similar efficacy with esomeprazole or lansoprazole. So I think the tegoprazan is as good as esomeprazole, but not as good as vonoprazan in terms of the acid suppression. But in some aspect, for example, NERD, tegoprazan might be useful drug. So in summary, also I just like to mention about the safety concern. And you're quite aware that a lot of adverse events have been reported because of the widespread use of PPI therapies. But not many of them are quite dramatic or influential. But vonoprazan is more potent than PPIs. So the hypergastrinemia is much more higher, actually. As you can see in GERD therapy, the patients are more acid secretors, but nevertheless, it shows very higher level of gastrin compared to the lansoprazole, as you can see on the left panel. And but if you look at the LDA maintenance therapy, much higher level of gastrinemia is observed because these patients are older and most of them may be infected with H. pylori. So you have to be very careful about the hypergastremia consequences in the long term. And also, because of the potent acid suppression, the duodenal dysbiosis, of course, for the dysbiosis in the lower gut might be a consequence, as you can see here. So we have to be very careful about the dysbiosis. So this is a summary, and there is at least advantage of vonoprazan over conventional PPIs, rapid onset, powerful acid suppression, and no influence of CYP2C19, and no influence on food. And superior effect of vonoprazan on severe acid-related diseases, as I've shown you. I don't go through this. And however, you have to be very careful about the drug safety for long-term use. So far, at least up to 2 years, there is no carcinoid tumors occurred, but overall safety profile has been similar to the PPIs. But for longer term, for example, if you keep using it for GERD maintenance therapy or low-dose aspirin or therapy, you have to be very careful about their long-term consequences. So we need further vigilance on this aspect. Thank you very much.
Thank you very much, Professor Ken Sugano. May I invite both of you sitting on stage. And now is a Q&A session. Yeah, Professor Kim, please.
I have a question.
Yep, go ahead.
As you mentioned, between the vonoprazan and tegoprazan, there are two major discrepancies, especially in Helicobacter pylori treatment and node treatment. One in Helicobacter pylori eradication is the vonoprazan is relatively higher eradication rate compared with the tegoprazan. You mentioned that the relatively low the function of acid inhibition, but can you expect in vonoprazan is the high dose vonoprazan therapy can get the more eradication rate of Helicobacter pylori? Can you guess one thing? And another thing is in other treatment, you mentioned is the lower acid inhibition compared with the vonoprazan, but is in other patient only tegoprazan has positive data. Only vonoprazan, only tegoprazan has positive data in other treatment. So if the tegoprazan has a lower acid inhibition, why the tegoprazan has get the positive data?
Thank you very much for your question. I have no experience on tegoprazan yet, so I can just guess the reason why tegoprazan was successful in NERD, but vonoprazan failed. One may be the choice of the patients. Although they did twice on vonoprazan clinical trials on NERD patients, the selection was not complete. Maybe functional heartburn patient may be involved because we didn't probably do any selection to rule out, exclude those patients. That's one reason. So the Korean study group might be more strict in selecting patients. That's one reason. The second reason may be acid suppression may not be too potent for those patients. Milder, even H2 receptor antagonists can do. And you probably notice the high rate of placebo effect. So that might explain another reason. The third is that, as I mentioned briefly, that the dysbiosis in the stomach is more profound in vonoprazan. Then those dysbiosis might cause upset of the stomach or duodenal. And duodenal microbiota might be now involved in functional dyspepsia. So those upset or dysbiosis in the stomach or duodenum might explain a little bit of the reason. You mentioned about the higher doses of vonoprazan for eradicating H. pylori. The 40 milligrams of vonoprazan in Japan is almost plateaued, actually. So you can keep it almost above 5 in Japanese patients. But in the European patients or Western countries, 40 milligrams may not be good enough. You may need 80 milligrams. We don't know yet. And another reason why they failed to achieve higher rate of eradication, and we'll chase, I think, data is that they use too high doses of amoxicillin, which upset the patients, complex. They use 2 grams and 14 days. And also the clarithromycin doses was high. So that causes a lot of, dysbiosis in the gut. I think excess amount of antibiotic use and too long, I think, management period might be rather against the better, compliance. So we can shorten, and dual therapy would be probably the way we should go.
And also, Ken, do you think that in a dual therapy for HP eradication, do we need to assess the CYP3A4 in some cases or in some situation before we prescribe the dual therapy? Because we already saw that when we have some data that using the vonoprazan base, some is not have a very high eradication rate, but some group is have a high eradication rate because of maybe the rapid metabolizer of the CYP3A4/5.
Well, CYP3A4 is relatively stable across the human beings. Very little differences among the people as compared to CYP2C19. And if the vonoprazan is metabolized across, use CYP3A4, as you mentioned, and the same for the clarithromycin. So it actually interact at the CYP3A4 metabolism. That works better for both drugs in terms of the eradication. So even if you use the same doses of vonoprazan, if you combine it clarithromycin, vonoprazan effect is enhanced. The same for the clarithromycin. So it actually not compete with each other, but enhancing.
Okay.
With each other.
Professor Leelakusolvong, please.
So thank you so much for your fascinating talk. So as you know, that right now is a follow to Professor Kim's questions. So now we have many of vonoprazan, just like rivaprasans, tegoprazans, and vonoprazans. Somehow they might have some drug interactions, just like a PPI. That's announced by the US FDA. They mentioned that some esomeprazole, omeprazoles, they might difference from the other kinds of PPI, and maybe not a class effect, maybe a drug-specific effects. For the PCABs, do you think that it might be any difference between the drugs and any class effect in terms of the drug interactions?
It's hard to answer the questions because now our experience is very limited. But at least for the binding site, the vonoprazan nicely, fit into the potassium pocket as compared to sharing 28082. I couldn't show the slide because of the limit of time, but the same potassium binding site was not totally blocked. The entrance was blocked, but the configuration of the fitness of the vonoprazan chemistry is better than Schering's product. And probably the same for the tegoprazan, although no crystallization study has not been done yet. And because of the high PK of the vonoprazan, the binding is much stronger and much more persistent than the conventional, PCABs.
Thanks. Jose, do you have Professor Rocha?
Yes.
Yeah.
Somchai, thank you. Ken, thank you very much for that elucidating talk. We did a survey in the Asia Pacific several years ago on how our Asian GIs would do diagnosis of GERD in the outpatient. And a good number of them suggested that PPI test is still a common outpatient test for diagnosing GERD. But among the Japanese, up to 66% of those surveyed already mentioned that they were using PCABs. So a question to you, and later on a question to Professor Supphamat is, For you, Ken, what is the dose of the PCAB when you do this PCAB test for the diagnosis of reflux in Japan? And my question to Professor Supphamat is, how do you think PCABs will be used as a diagnostic test for GERD in the ASEAN countries in the future?
My answer only for Thailand, because due to the cost of this drug, even the proven efficacy, but the cost of this drug is quite high. So we cannot use as a 1% test instead of PPI test just now.
Yeah, I think the PCAB test, especially vonoprazan test, is now conducted in Japan, and there is some data presented already. But no standardized, doses and duration was not achieved. So maybe 1 week, you can shorten the 2-week period of PPI test to 1 week, or even 3 days. But how much dose you use was not decided yet.
Okay. Maybe the last. Okay. Professor Varosha first, and Professor Francis Chan, maybe the last two questions. Yep, Professor Varosha, please.
Maybe to Ken. You use dual with PCAB amoxicillin. What do you do when amoxicillin allergy? Which one you use? I know keratomycin is not good in Japan.
Well, in the case of amoxicillin allergy, you have to confirm amoxicillin allergy, because the American Journal of Gastro paper shows by Bill Chase group that almost more than half of the so-called penicillin allergy patient is not really penicillin allergy.
Only by history.
Yes, but real penicillin allergy patient, you will be incriminated. So in the case of real, true penicillin allergy, you have to switch to tetracycline or maybe new quinolones like,
Still dual?
Well, in that case, you can use metronidazole, because in our country, metronidazole resistance is very low.
Dual don't work too well in Thailand. We did 14 days, and we're not sure whether it's a fake of CYP3A4 or 5, like Dr. Somchai said.
Okay.
So we try high dose vonoprazan, and also another one, quadruple vonoprazan, seem to work better. So it remains to be seen. That's a pilot. We have to do more. And lastly, if you use vonoprazan, you care about antibiotic stewardship.
Yeah, in the case of new quinolones, we can use citalfloxacin rather than levofloxacin, because levofloxacin is now getting higher resistant rate. But citalfloxacin can overcome some of the resistance, new quinolone resistance. I'm not sure if you can have the access to this new citalfloxacin.
We can do that. Yeah.
I just want to make 2 points. First of all, I'm quite concerned with the study results by Bill Chase Group, showing that in Europe and in the United States, vonoprazan-based eradication therapy seems to be rather disappointing. In particular, adding erythromycin doesn't really help. So I just wonder if, say, in other populations, we should use vonoprazan-based dual therapy rather than triple therapy, provided that we are kind of happy with the outcome with the eradication rate. Seems that the eradication rates are pretty poor. My second point I want to make is about the study design of vonoprazan versus PPI in esophagitis. If vonoprazan is really superior to PPIs, I believe in future all these studies should be a superiority design rather than a non-inferiority design. What's the point of telling people that vonoprazan is not inferior to other PPIs if, in terms of pharmacokinetics, it is superior?
Yeah, thank you very much for your comment. And the dual therapy, the Bill Chase report, was using super high dose of amoxicillin. It's too much, actually, 3 grams or something. So super high dose of amoxicillin causes harm to your gut.
Yeah, I think time's up. So this session is a very informative session. So before closing this session, I would like to sincerely thank the Takeda Pharmaceutical Company again, and would like to thank my co-chair, Professor Jose Sollano, Dr. Supphamat, and Professor Ken Sugano. Thank you very much. I would like to call this session closed. Thanks.